Well, good evening, everybody, and welcome to this webinar. We're going to be talking about fetal alcohol syndrome disorder, and we're going to be looking at how and why we should be making this diagnosis. I'm Sandy Vincent from the PHN Education team, and I'm joined tonight by our presenters, Dr. Mina Rattan and Olivia Gregg. Before we begin, I would like to acknowledge the traditional custodians of the land that we live and work on. For me, that's Darkinjung land, and pay my respect to First Nations people for their enduring culture and contribution to this vast region. A few things to let you know: that this session is being recorded and the recording will be available on our PHN website in a few days' time. An evaluation will automatically come to you after the session. Please do complete that, as the feedback is really important to us. If you've got questions during the presentation, please use the questions box in your panel. If you just click on the little tab, it'll open up the questions box and you can write those in to us and we'll review them at the end of the session. It's my great pleasure to introduce our speakers. Olivia Gregg is a clinical nurse consultant and GP liaison for child and adolescent mental health on the Central Coast. And Dr. Mina Rattan is Head of Department Pediatrics at the Wyong Pediatrics Unit and Staff Specialist Pediatrics at Wyong Hospital. So I'd like to ask Olivia to please launch her presentation for us tonight.
Thank you, Sandy.
All right, there we go. That should be coming through. That looks good. Perfect.
Good evening, everyone. And thank you very much for joining us, and thank you to Dr. Rattan and thank you to you, Sandy, for all your valuable contribution. Hello, everyone. My name is Olivia. I am the clinical nurse consultant and GP liaison for child and adolescent mental health. I just want to briefly run through the criteria and the referral pathways for young persons under 12 years of age. Mainly the main criteria to refer to our service is functional decline in 2 or more domains, either school attendance and or at home, and also to have moderate to severe risk of self-harm or expression of suicidal thoughts. Part of the referral criteria too is that the young person has to have had contact with at least 2 other services, such as psychology or counseling, and they were not effective. Recently, we've been having a spate of referrals from GPs for under 12s, mainly asking for diagnosis, assessment, and medicating young persons with neurodevelopmental orders. Unfortunately, CAMS, we will not offer any assessment. We are unable to offer assessments, diagnosis, or medication for young persons with suspected neurodevelopmental disorders such as autism or ADHD. Also, as well, we are getting referrals that is requesting a one-off psychiatry review for medication or for diagnostic clarification. What I would like to really make clear to the GPs who is responsible for that service and who can provide that service for a GP and for the young person. Basically, neurodevelopmental disorders are the domain of pediatricians. A private clinical psychologist will need to complete an assessment, and then a diagnosis will be formulated by the pediatrician. Dr. Rattan has kindly advised me earlier on that the best thing to do really is first have the young person be reviewed by a pediatrician to confirm the presence of a neurodevelopmental disorder or not. That will save the young person and the family the cost of going off and completing the assessments, which probably might not be necessary. These assessments, unfortunately, are not publicly funded. They have to be paid for privately by the young person, either through NDIS or through private health cover or just privately. Referrals for the under 12s to come to CAMS. At the moment, CAMS is only accepting referrals that are coming to us from a GP. There is a special referral form that is available on Health Pathways. Please download that form and complete it. If you are unable to access that form through Health Pathways, call our office on 43047878 and ask our admin officer, and we can fax or email you a referral form. Sometimes GPs, and I know everybody is time poor, You can always call me on the mobile, the GPLO mobile 0458 786 186. I am more than happy and willing to forward the referral to you. Unfortunately, we are unable to process any referral until this form is completed and received by CAMS. So what happens after we receive the referral? We will contact and if this referral is appropriate and meets the criteria for the under 12 team, I will usually contact the family or the carer and arrange for a mental health assessment. Once we've completed the mental health assessment, that young person will be allocated to the under 12 team. If the referral does not meet the criteria, I will always come back to the GP and offer alternative recommendations for the family. And also I will link with the GP and inform about the outcome of the assessment, whether we have accepted the young person or not. Sometimes, and recently we've had 1 or 2 referrals. The family were advised by the GP to call the mental health triage access line, which is the 1-800 number, and refer the young person. At this point in time, the mental health triage line is unable to accept any referrals for under 12s. So technically the referral has to come to us through the GP. Please contact me, please liaise with me, and we can always discuss if the referral is suitable for us or if it should be directed to a pediatrician. Sometimes the GP will see a young person and will have serious concerns about what is happening, especially around risk and safety. Only in this situation, then advise the family to attend emergency department for an assessment. The issue we have with attending ED, it's an extremely stressful event for the young person and for the family. Recently, ED has been absolutely flooded with young persons. Some people can wait up to 8 hours in ED for an assessment. And the process involves first the young person will wait and then be reviewed by a pediatric registrar. If the pediatric registrar has any concerns around mental health or safety, then a mental health registrar is called and the young person will then have the mental health assessment, then referred to CAMS. However, that doesn't mean it will happen immediately one after the other. There could be another waiting period between the pediatric registrar and the mental health registrar. We could be looking at probably 12 or more hours. That's why it is really very stressful. So think carefully before you recommend a young person, especially the under 12s, with the carer to attend ED. When you're assessing an under 12, I found this really valuable tool. It says the 5 S's. Is there any concerns around safety? What are the behaviors? Where are these behaviors happening more or less? What is the triggers behind these behaviors? And then has that young person had any previous contacts with any services? If you can include as much of this information on the referral form, will be extremely helpful for us to then contact the family and arrange for a mental health assessment. I just included a couple of other services that are available, especially for the under 12s. I'm not going to go through them. They're pretty self-explanatory on the slides. But please, if you have any concerns, just give me a call and let me know. And I am more than happy to discuss with you on the phone. I'm more than happy to email you other supports that are available and offer as much support to the GP, because this particular cohort of young persons are very vulnerable, especially around safety and risk. Little Sparks Beam Health is a brilliant program. It's funded by the Health Network. It provides mental health support for children under the 12. They have trained psychologists. They have also mental health support clinicians, and it also provides support for families experiencing any financial hardship. I've included an email or a website. Please refer directly to them, and then the team will contact the parent and the caregiver to discuss support. However, please be aware this is not an acute service. So is CAMS. We are not an acute service. When there is pretty high acuity, then the GP can consider ED. Thank you, everybody, very much. I just don't want to take of the lion's share for Dr. Ratan because I know she is amazing and she will present a brilliant presentation. So thank you, Sandy, and thank you, Dr. Ratan.
Thank you, Olivia. That was excellent. Mina, are you ready to share your presentation?
Yeah.
Beautiful. That looks perfect.
Yeah.
Yes.
Welcome, everybody. Good evening and a very welcome to all of you. Thank you so much, Olivia, for giving an outline of the different services which are available to young people, especially under 12. I think the topic of presentation today is fetal alcohol spectrum disorder. The GPs, being the primary care providers, are the first contact for the families and young people with any neurodevelopmental problems, and FASD, which we call it as a mnemonic, is one of a fast emerging condition. So today is our opportunity to understand how and why we should make this diagnosis and what information we need to know so that we are able to diagnose and make appropriate referrals. So with that introduction, I'm going to present the topic. So as you know, FASD is a lifelong but preventable neurodevelopmental disorder which is caused in utero or perinatal alcohol exposure. Perinatal alcohol exposure actually causes diffuse, permanent, and irreversible damage to the fetal brain and frontal lobes, resulting in lifelong dysfunction and disabilities. It's a type of acquired brain injury, and the reason we call it as spectrum disorder is because it encompasses a lot of situations or presentations and manifestations. Now, what do we know about FASD? Regarding its epidemiology, of course, in Australia, it is poorly known, just like in many other countries. There was a study which was done by APSU on fetal alcohol syndrome or partial fetal alcohol syndrome. Um, and according to this study, which was done in between 2001 to 2004 by Elizabeth Elliott, who is one of the leading clinicians at Westmead Children and has done an impressive body of work in this area. It mentioned that the FASD incidence per annum is 0.6 per 100,000 children in especially young people less than 15 years, and it is considered to be still a significant underestimate because of lack of awareness about this condition and also lack of appropriate diagnostic evaluation tools. There are few other studies which are mentioned. They were done in high risk populations, so the prevalence was found to be higher if you consider the studies in a high risk population, just like vulnerable groups as out of home care children. Now, FASD is actually not a rare disease. US and Canadian data suggest a prevalence of about 1 to 2% of the population, um, according to another study which has been done there. So, FASD is the most common cause of preventable developmental disability. So, this is one of the neurodevelopmental disorder which we can actually prevent. How we can do that is by providing education and awareness to the females in childbearing age so that they are aware of the consequences of alcohol. Now, kids with FASD or young people with FASD is in everybody's caseload, whether it is pediatricians, whether it is GP, and it is also a misnomer that it is more common in certain ethnic populations. In fact, it is common in all ethnic populations. Most of the young people or children, they are missed or not diagnosed with FASD because they are given a false labels of or misdiagnosed with conditions like ADHD or intellectual disability, learning disorders. The other reasons are that there are missed opportunities for optimal management and prevention of this condition. Outcomes can be improved by early diagnosis and intervention. Now, there are three key aspects when we want to diagnose FASD. So, growth deficit is something which is not a major criteria, but for diagnosing FASD, the three other key aspects which are really important is prenatal alcohol exposure. Of course, if that history is not confirmed, you cannot consider it as a possibility. Second is the facial abnormalities, which we call as sentinel features of diagnosing fetal alcohol spectrum disorder. And the last one is CNS impairment. Now, moving on to the diagnostic criteria. So, as you can see, you can diagnose fetal alcohol spectrum disorder in two situations. If the three sentinel features, which we are going to talk about in next few slides, are present with or without available prenatal alcohol exposure, and there is associated neurodevelopmental impairment, then of course you can diagnose it. However, it is also interesting to know that you can diagnose FASD, that is fetal alcohol spectrum disorder, even if the facial features are not present. But in those cases, there needs to be confirmed history of prenatal alcohol exposure and neurodevelopmental impairment. The facial features may be there or may not be there, but not all of them may be there as well. So when we talk about the prenatal alcohol exposure, we actually strive to get as much as information as possible so that we can confirm the exposure in the female or the mother of the child. When we talk about neurodevelopmental impairments, that talks about different domains which we look into in terms of the functioning of the brain, and I will give you a little bit insight about those domains in the next few slides as well. Neurodevelopmental impairment can also happen due to structural abnormalities like microcephaly is there or some other sort of structural abnormalities are there. In terms of function, there can be cognitive difficulties, communication difficulties, or the patient may present as uh, defective adaptive behavior as well. Now, when we talk about the facial features, the three sentinel facial features which we want to emphasize is the palpebral facial length. This is usually less than third centimeter, acceptable for particular ethnic population. The philtrum is smooth, and usually you can do ranking for it as rank 4 or 5. There are certain guides which are available. Of course, that's not something we are hoping GPs would be doing. This is just for your information so that you can know how soft, smooth philtrum is categorized. And the other last sentinel feature of FASD is thin upper lip. So as you can see in these slides, effect of alcohol exposure during pregnancy can affect the brain development at any stage of life. It can be in periconception period, it could be in first trimester, second trimester, or third trimester. Depending on the time of exposure to alcohol, it can affect the fetus in different ways. In periconception, as you can see, there could be some long-term renal, metabolic, cardiac issues. If you have the exposure documented in first trimester, you are most likely able to find the facial abnormalities, and this can also result in major structural abnormalities of the brain. If it is in second trimester, of course, it can cause increased risk of abortion and fetal wasting. Third trimester exposure usually leads to low birth weight, and it can affect the well-being of the baby, and there can be stillbirths if the amount is high. Now we talk about the factors that mediate the impact of prenatal alcohol exposure. Of course, it is really dependent on the timing. the amount and the frequency of alcohol intake. It does get influenced by what is the age of the mother, how is her general health, and what are the genetics. And it is also governed by fetal genetics and neuroplasticity of the brain. Now, the standardized approach to asking about alcohol is really important so that you are able to assess how much of alcohol intake was happening at different periods of time, and that allows you some clinical judgment and also help with careful evaluation of that information to provide confirmation of alcohol use and quantifying it at the same time. Now, in terms of the evidence of exposure, it can be evaluated and categorized into 4 different categories. So, no exposure, it means that if there is no exposure, then there can be no risk of FASD. If there is unknown exposure, for example, if the patient comes to you from a residential placement or a group home and the antenatal events can't be confirmed, but you are suspecting it, then it is an unknown exposure. Confirmed exposure is when you have confirmed the quantity of that, but the score is between 1 to 4. So, how we score it is dependent on certain criteria, which I will tell you briefly. And the next one is the confirmed high risk exposure, in which there is 5 plus score, which means that the patient or the child will be at a very high risk of developing FASD if that kind of history of alcohol exposure is available. Okay, so when do we consider high risk exposure? Confirmed high risk exposure for FASD is considered to include at any time during pregnancy a score of 5 or more. Okay, and reported consumption of 5 or more standard drinks on any one occasion, or if there is other reliable evidence of high alcohol use available to us. For example, drink driving, accidents, or involved in those fights. Now, when we have to start the conversation, I think all of you do it every day. You have to be very sensitive to ask um, the questions without coming across as judgmental. And since it is a sensitive information, you also need to ensure the confidentiality. You can start the conversation by asking some general questions about the pregnancy, whether it is planned or unplanned. When did she realize that the lady was pregnant? Was she drinking before the pregnancy was confirmed? Did she modify her drinking behavior after she found out um, that she is pregnant? And in which trimesters, how much quantity was she taking? So the audit C, which is kind of questions which we use that helps us to make the scores which we were talking about, that is the audit C scores. That is the combination of these 3 questions and the scores somebody scores on the answers to these questions. For example, the first question is how often the birth mother has a drink containing alcohol during pregnancy. So you can see in the choices, never, monthly, 2 to 4 times a month. So depending on frequency, you can score that. The next question is about how many standard drinks did the birth mother have on a typical day when she was drinking during this pregnancy, and how often the birth mother have 5 or more standard drinks on one occasion during the pregnancy. And if the total score is between 1 to 4, that actually is the confirmed exposure, but 5 plus is confirmed high risk exposure. So in females where you have 5 plus scores are the kind of babies who are at a very high risk of developing FASD. So now we talk about what are the standard drinks. I think everybody is aware, depending on which drink you are selecting, you need to know how much quantity constitutes as standard drink. and many single serves bottle cans contain more than one standard drink, so you are able to get a rough idea of trying to quantify the amount. Now, according to some of the facts of alcohol use during pregnancy, according to Australian National Drug Strategy Household Survey, which was done a few years back, about 4 in 10, that is 42% of Australian women consumed alcohol during pregnancy, um, whether they knew they were pregnant or whether they were not aware. And more than half, that is about 56% of Australian women had consumed alcohol while being unaware of their pregnancy. And a quarter, that is 25% of women, continued to consume alcohol even once they were aware that they were pregnant. So you can see that it is very, very variable how the females will change their behaviors in terms of alcohol exposure or consumption after knowing the fact that they are pregnant. Most of them, of course, they will modify, but then 26%, which is a very high percentage, may not change their behavior. Another study which was done by UNSW also talks about fetal alcohol exposure early in pregnancy is highly prevalent. Heavy or binge drinking during pregnancy was more common than low level drinking. And most women, as we discussed in the last slide, reduce or cease their alcohol consumption once they become aware of their pregnancy. Now, the factors which are associated with decisions to cease, reduce, or continue drinking depends on use of alcohol prior to the pregnancy, how frequently they were drinking, whether they have any sort of dependence on it, what is the age of the mother, whether they are having concomitant smoking behaviors, and recreational drug abuse as well. So we have already covered how to start this discussion. Now, on the next slide, we will talk about neurodevelopmental impairment, which is actually the most important and most definitive criteria in terms of making a diagnosis. So you cannot make a diagnosis of fetal alcohol spectrum disorder if the neurodevelopmental impairment is not there. Now, the neurodevelopmental impairment is actually the hallmark feature of this disorder, and it can look different in different patients. It could be that there is a structural damage leading on to, microcephaly, or it can have normal fetal brain development but cause behavioral problems or learning issues as they grow older. The brain damage is not necessarily associated with impairment, which causes characteristic of FASD facial abnormalities. Now again, it can affect the brain cell function, both the neurons and supporting cells like glial cells. And there can be evidence of tissue and brain imaging research which can give you an idea about these consequences. Of course, if there are abnormalities in glial cells, it could lead to abnormal neuronal development, reduced neuronal survival, disrupted brain architecture, defects in the impulse transmission, and abnormal brain plasticity. And similarly, microcephaly is something which can affect the growing brain, and it can affect the proliferation and survival of the neuronal cells. So these are some of the pathological and physiological basis of neurodevelopmental impairment in this condition. Now, when it actually happens, what does it mean? It can affect any of these domains. Um, and we have discussed in the previous slide that at least 3 of these domains have to be affected, more than a significant percentile to be classified as neurodevelopmental impairment. So either there should be a brain structure or neurological impairment, motor skills may be affected, cognition, language, academic achievement, memory, attention, executive functions, affect regulation and adaptive behaviors, social skills or social communication. So any of these areas, if they are affected, at least 3, then it would be a very strong indicator of FASD. Now, the rationale is that there should be evidence of prenatal alcohol exposure causing pervasive brain dysfunction along with recognition of the neurodevelopmental impairment. Now, evidence of severe impairment may be attributed to prenatal alcohol exposure when other possible causative factors have been considered or excluded. So you always have to keep your differentials open. Now, what type of patterns you can see? So the neurodevelopmental patterns, they can be very, very different. So there could be combination of different factors or domains which are affected to different extents. Um, Nevertheless, problems such as deficits in attention are frequently identified in individuals with FASD. So it is not uncommon to have ADHD-like symptoms in FASD, which makes it even more confusing. The clue to its diagnosis is that these patients with ADHD are very difficult to treat. So if you have a treatment resistant ADHD, which is requiring multiple changes in terms of medications for ADHD in a young person, that is an indirect clue to you to make a alternative differential diagnosis. Now, whenever you see a patient with suspected FASD or fetal alcohol spectrum disorder, you just do the examination and assessment process just like you always do by making sure that you do the head circumference, you do a thorough neurological examination, developmental assessment, and that's exactly what the pediatricians do. So you can explain to the families once the referral is done, and some of the basics GPs do it very well. So they would provide us with the baseline. And there are certain patients who may require or benefit from specific investigations like brain MRI or genetic screening. So depending on what part of the brain is affected, you can see certain specific disorders in young persons. So I won't go too much in detail for that, but it is just to tell you that if there is microcephaly, then the head circumference, as the name suggests, would be low. If there are structural abnormalities, they will be visible on the MRI, and so is the seizure disorder or neurological diagnosis. Now, when we talk about the severe impairment, this is defined as a score of 2 or more standardized deviation below the third percentile. And there can be also quantification in terms of IQ assessment. So if the full scale IQ is less than 70, or you can also do a non-verbal reasoning score of less than 70, that can also be considered as severe impairment. Now, evidence of significant discrepancy between major subdomain scores also constitutes evidence of severe impairment. For example, one is scoring a little bit high and other is very low. So that kind of discrepancy cannot be explained by ADHD alone. So there needs to be an overall assessment which takes into account all these factors. So FASD is a treatment-resistant ADHD, as I mentioned. So these young people or group of children will have a lot of problems with their executive functions, which constitutes time management, planning, organization, and prioritization. They will have difficulty in goal formation, planning, and carrying out those goals and doing them effectively. And there are several studies to support that. So I think it will become easier if I give you an example. For example, if the teacher tells the children to get out their maths books and do questions, um, 1 to 10, each pupil must understand this in terms of first getting out the textbook. Okay. Also the pencil and the eraser, so the tools which they need to use to carry out that assessment. Also clearing the desk of the previous things which were on their desk without getting distracted. Then they must understand what they are supposed to do. They need to plan their tasks, do a start, and then complete the task in a reasonable period of time. So these are all executive skills which can get affected in a child with FASD. So general rule is that most of the students, once this kind of instructions are given by the teacher, they will get started without about, thinking about it, because they are already prepared at subconscious level. But a child with FASD or severe ADHD often struggle to do that. So the executive functions are high order processes, and they require um, the ability to delay responding, to shift between different activities flexibly without getting stressed or anxious, and planning the task well. So these are some of the skills which does get affected, and in the picture you can see the areas of the brain which helps with our attention and judgment. So another way to think about is that executive functions, they are just like a bicycle wheel which has got many skills, such as the ones we have mentioned above, those 10 domains that comprises it are the spokes. So it is possible that if one or two spokes are damaged, you can still feel that the wheel can get affected. FASD students are those whose executive functions are compromised, may have only one or two of these skills affected, but they are affected severely, which can impact their overall functioning, and that can affect their learning ultimately. So these are, if the working memory gets affected, then they will be forgetful, they will miss all the information, and these are all the different things which will help to give you an idea that their working memory is affected. If the pulse control is if affected, they will be very disruptive. They call out, act out in the class. If organizational skills are there, um, criteria which is most affected, then they will struggle to do organization which is required to carry on their learning tasks. And the next one is time management. So they will often not be able to complete the task in the time which is allocated. And same is true for mental flexibility, internalizing language, and attention and affect if they are affected. So I will give you some idea about the sentinel features. We have already discussed that it is the length of the palpebral fissure which we take into account. You can see in this diagram that the philtrum is very smooth and there is thin upper lip. So these are the three main features. And these are the calipers, how we actually measure them. So this diagram is just trying to reinforce the fact that it can be present in all ethnic populations. So you can see these children belong to different ethnic population, but they have got similar sentinel features. Okay, so the assessment methods which are used, they are quite standardized. Either you can use a lip philtrum guide or a measurement caliper, or some higher centers are also using facial photo analysis to determine some of the subtle features. Okay. So I think you can see in these pictures that there are certain features of FASD which are quite classic, and you will not be missing those. Now we come on to the other part, that why should we make the diagnosis? It's really important for parents and caregivers that ultimately the diagnosis of FASD, if it is available to them, it will actually help them to develop some realistic expectations of their child's capabilities and support their learning and future goals in that particular direction. So some of the parental comments are really important, and I have highlighted them because some of the parents felt, this is from a study which we did at Children's Hospital Westmead regarding the impact study of fetal alcohol spectrum disorder, and parents felt that we didn't know what was wrong with our child, and he was 4, and we were just getting very frustrated because they were not getting anywhere with him. Everyone kept on saying that it is parenting, and that's exactly what we always have to consider as one of the factors when we see a young person with behavioral disturbance. But it is also important to take into account other differentials. And once the diagnosis is made, then the parents know where to focus on and how to help their child in the best possible way. The reason we want to diagnose is not to give them a label, we want to help them with functional support. So, as pediatricians, allied and mental health practitioners, we diagnose these conditions and provide functional support to our patients, which includes providing appropriate early intervention services, enhancing understanding of child strengths and weaknesses, and the needs by the parents as well as the teachers. The other reason we want to diagnose it to prevent it, because it is a preventable neurodevelopmental disorder. We want to advocate in, improve awareness so that it can be considered as an diagnosis, and it is considered as a problem which can be actually cured and prevented. So in terms of screening for FASD, there is no validated standardized screening tool which we can use, but it does involve some specific assessment, which could include developmental assessments, behavioral assessments, taking into consideration the physical features, and also doing some sort of questionnaires or formal assessments to assess the cognitive functions depending on the age of the child. The other thing is that there is partly related to wide spectrum of possible neurodevelopmental impairments in FASD, and they are present in terms of variable, percentages. So it is really difficult to get validation. Screening of general population, if you say, it is not a cost effective strategy because you just need to focus on high risk groups or consider it as a broad differential in patients who are not responding to usual treatment and supports. Further research, of course, will be required to develop a validated screening tool for FASD as the years progress. But at this stage, what is really important at primary provider care level is to find out whether there is confirmed history of alcohol intake or not. As you would see, alcohol use, we often ask our patients. So it is really, really important that we continue to do that in a sensitive and respectful way. And discussion of the drinking and trying to quantify the alcohol exposure if possible and document that, because that history is very, very important moving forward. Now, it should be considered as a differential diagnosis for any significant developmental, behavioral, learning, or mental health problems in a young person until prenatal alcohol exposure is excluded. So, you need to consider it as a strong possibility in different domains. So, whether it is a developmental problem which is not actually improving behavioral, learning, or mental health issue. So, it can present in any of these forms. Assessment of FASD should be considered in all children with a neurodevelopmental disorder of unknown etiology, where there is confirmed history of uh, perinatal or prenatal alcohol exposure. Now, support and consent is really important as part of referral process. As Olivia was telling, that it is really important to provide an appropriate referral. So, taking into account what are the needs of your young person, caregiver, or a family member who is dealing with this kind of young person, and trying to direct them to appropriate services which are available, trying to make appropriate referrals to the pediatrician who can help in some facilitating some of these discussions and supports is really important. When you make the referral, it's also crucial to take an consent, which is obtained from the caregiver, so that they are aware that and give you permission to actually make a referral. So just coming back to when you want to refer, clinician should refer an individual for diagnostic assessment or consideration of FASD when there is a confirmed exposure at a high risk level, neurodevelopmental impairment, and history of alcohol exposure is confirmed. And this is irrespective of whether or not they have facial features, because we did go in the previous slides that actually it can be diagnosed even if the facial features are not there, or even if they are less than 3. If there is microcephaly and prenatal alcohol exposure, then also you need to refer to FASD clinic. At this point of time, FASD clinic is only in Children's Hospital Westmead, and they take referrals from all over the state, and they have got very strict criteria of accepting. So usually they will take the referrals not from the um, without any appropriate assessments. So they often like to have the baseline assessments done and the patient being managed by a community pediatrician before it is accepted. And of course, if the parents or the caregiver is giving you a concern that maybe it is FASD, because FASD, as you know, has been recently added to the list of NDIS funding support. So it's really important that if the parents are concerned, then also they should be offered um, an opportunity to get it diagnosed or at least helped with. So the referral threshold is a bit lower if you are dealing with a child or young person from a vulnerable group, a high risk group, which we say, for example, in out of home care children like adopted or foster children, those who are in with juvenile justice, who are living in a community known to have high rates of drinking, whose birth mother has known alcohol related illness or dependency, and there is already a family member with fetal alcohol spectrum disorder. So in these patients, you really need to refer them appropriately and adequately at a reasonable period of time. So the take home messages from this presentation is that there needs to be clinician education about the diagnostic criteria, how and when we should consider it as a differential diagnosis. Uh, Also needing to emphasize that in our day-to-day history taking, we really need to make sure that we are asking about alcohol use in pregnancy in a sensitive and non-judgmental way. It's really important to have planning, diagnosis, support, and disability services involved in the care of a young person in these groups. And children and adolescents with FASD may be hidden in our caseloads, in our general practices, whether it is pediatricians or mental health clinicians they deal. Now, current diagnosis may be ADHD or ASD or intellectual disability or learning disorder, and if it is having suboptimal support or outcome despite the support which you are providing, then also it is really important to consider it as a differential. And what do we do about it? We define the neurodevelopmental disability and try to aim to do what we do with children with intellectual disability, autism, a traumatic brain injury, or ADHD. So try to link them with supports in the community, appropriate mental health clinicians, psychologists, occupational therapists, and school counselors. Try to explain the behavior and shape the expectations based on the disability in young person. Treat medical comorbidity like chronic illness, making FASD look more worse than actually it is. Treat psychiatric comorbidities if they are present, for example, identify anxiety, depression, and addressing them with appropriate psychology input and medication. And last but not the least, keep on increasing the awareness to prevent it happening in future, because it's a only preventable neurodevelopmental disorder. Rest of the other disorders you can't prevent, but FASD you can. So it is really important to start working towards primary prevention, which will be very cost effective in terms of resourcing in the years to come. So these are the conclusion or take home messages, which highlights the opportunities and need for clinical service provision, assessment services and procedures, and post-diagnosis care, and also ongoing development of diagnostic and support services and FASD informed clinician education. And with that, the presentation comes to an end, and these are all the references which are available. Hope you have enjoyed this presentation, and if there are any questions, you're most welcome.
Wonderful. Thank you so much, Meena. That was really excellent. All right, folks, we actually don't have any questions, but let's just pause just in case because we have got time for you to send through some questions. Again, it's just in your panel. There should be a little box with questions. If you click on the arrow and then open up the box, you can write your questions, or you can also unmute yourself if you would like to ask questions directly to Meena or Olivia. Okay, Ronnie is saying I can't unmute. I might be able to do that for you, Ronnie. No. Oh, here we go. Sorry, Ronnie, I wasn't able to unmute you either, but Ronnie is asking, are there any other options for diagnosis other than Westmead?
I think from the GP point of view, their first point of contact should be the pediatrician, because they, in terms of providing appropriate assessments and some medication support if needed, the pediatricians can help them facilitate some of these things. Unfortunately, apart from Children's Hospital Westmead, there is no specific FASD clinic which is available for accepting referrals. But I think sending the patient to pediatrician will help in a better way to facilitate some of those assessments which are required.
Thank you for that. It doesn't look like we've got any more questions coming through.
I think since the presentation will be available for everybody on your website, I'm happy to take any questions or queries regarding the topic. I also feel that if there is any questions in terms of services which are available locally in Central Coast, I'm sure Olivia and myself will be able to direct the primary care providers towards that, because at the bottom of it is the kind of care which you provide to your patients and which is very, very valuable. And supporting those families who are struggling with a lot of vulnerabilities and complexities is something which we can do together as a team. Pediatricians and primary care providers have got great, huge responsibility of not only supporting our patients and families, but also providing them ongoing support and care, and trying to provide education and awareness and linking them with appropriate services or groups where they can get more information.
Awesome. All right, folks. Thank you very much to both our presenters tonight, Meena and Olivia. Thank you for joining us. Yes, we will most definitely. Pleasure. And yes, we will most definitely have this recording will be going up onto the Education Library website and a PDF of the slides. But what I will do is make sure that for everyone who joined us tonight, I will send through the PDF slides as well to your email addresses. So thank you very much for taking the time to join us tonight. So I would just like to say thank you and good night to everybody, and have a very good evening.
Thanks,
Thank you.
Jenny. Thank you. Thank you.
Thank you, everybody.
Thank you.